Okay, thanks everybody. So my name's Greenwood. I'm based in the University of Sussex and Sussex Partnership. I'm going to be talking to you about implementing a risk calculator for psychosis in clinical records in Sussex. So I'm going to talk a bit about the research, the natural language processing approach, the calculator application, the patient-public involvement, which has been really critical, and the precision psychiatry intervention approach that we're now looking at feasibility for. So the backdrop of this was that we have substance use and emotional disorders, which are potentially risk factors for people developing future psychosis. We know we have high rates of both of those in Sussex, and we also know that few people who are at greater risk of developing psychosis are actually identified as such. We know that from previous research, and we know that therefore they might not be getting the right support that they need at the right time. So in Sussex, as you've just heard from Liz, we've been implementing in Sussex Partnership the CRIS system, which is the Clinical Record Interactive Search System. It's a de-identified set of the entire electronic health record for Sussex Partnership, care notes, including structured and unstructured data, so it includes the written case notes. The option here is then to allow this, as we were hearing from Liz, to use this to build risk stratification tools, to identify groups at higher risk and so on for future clinical interventions. And what we wanted to do with this particular project was to look at what place a transdiagnostic risk calculator might have in targeting a subgroup of people who might be at greater risk, might have greater needs for mental health support in Sussex and Kent, and to see if that's valuable for those individuals. So there were two parts to this. The first part is looking at the feasibility of implementing a risk calculator in real-world practice, and the second part was looking at the feasibility of providing targeted psychoeducation, care pathway information, training and so on to individuals who might be at greater risk, and looking at the value and impact of that. So the risk calculator that we were adopting was developed initially in King's by Paolo Fusar-Poli, and it includes 4 core elements, which are age, sex, ethnicity, and the initial presenting diagnosis. But it also includes 14 additional natural language process concepts which are taken from electronic health records. So in terms of that structured and NLP derived data, this is a bit of an example of how the structured data that we routinely use in research and for mental health minimum data sets is just the tip of the iceberg of all the data that we have available. So it's only about 10% of the data we use. There's the large majority of data is that bottom part, which is unstructured written care notes. And the challenge is, how do we use that data in a useful way for patients when we know it has lots of useful information in it? You can see at the bottom here, it's got information about diagnosis, signs, symptoms, service use, and so on. We want to be able to make better use of that information. So this is an example of how we might create information from using natural language processing. So we take those 14 initial constructs, things that we think from research might be important. We identify informative case notes, we annotate them, we fine-tune a model, we apply that model to the data to develop structured fields that indicate the presence or absence of that information that we can then use for research. We've been applying that with this particular model in Sussex, implementing the models, fine-tuning them with human annotation, overseen by clinical advisors, removing anomalous extracts, and ending up with the bespoke model, which was what we were initially using in Sussex. We wanted to make sure that we had at least 200 scripts that we were starting with to have the best chance of accurate data being extracted, and we used a method to re-annotate pre-existing case notes in order to kind of accelerate that model. And what you can see here on this graph is that the large majority of these, we had over 200 case notes to develop the natural language processing. This is an indication of the accuracy that we were achieving. We were aiming for that final column, the F1 score, which is a measure of precision and recall accuracy, to be over 80% for each of these. And that was what we were doing. That's the initial work that we did to develop the model in Sussex. What we've now been doing is working more closely with the Crivia as they've been developing more of their own signs and symptoms, natural language processing, to use what is now their standard model and which can also be applied to other trusts' data across the UK, and to also develop natural language processing for diagnosis, which I'll come to in a moment. So, in terms of applying the calculator, the first aim was to look at this retrospectively, because we obviously have this data, so we know who's already developed psychosis. So we've got all of the data since the electronic health record started in 2008. We're looking at everybody with a non-organic, non-psychosis diagnosis, because we want to know who transitions to psychosis. We want them to have all of those indicators present and to have at least 3 months data so that we can look at change over time. We had to do some extra work in Sussex because only 10% of our patients had diagnosis in a structured field. So we've had to do some natural language processing work to extract diagnosis from case notes and to make sure it relates to the person and the diagnosis is present. And for the whole sample, we started with over 430,000 patients' data, obviously in a de-identified format. 40,000 patients had a non-psychosis, non-organic diagnosis, were over the age of 18 and had enough information to go into the model, and these were their diagnoses. Over 3,000 of those, so 7%, transitioned to psychosis, and we'll be using the NLP and the structured diagnosis. The model achieved a concordance rate, which is an indication of how good the model is, of 0.65, and we're working to increase that at the moment. The next thing we did was we set a threshold, which has been used in previous research, which was equivalent to 5% of people transitioning into psychosis in 2 years. We used that threshold and looked at data since the electronic health record started, and we could see that that had a transition rate of 16%. And we've then looked at it just in the last 2 years, and we can see that the base rate for transition for everybody who we were interested in was 1.5%. But if you set that threshold that we were looking at, we have over 6% who transition, so a fourfold increase. What we're now doing is prospectively identifying individuals who are above that threshold and therefore at potentially greater risk of future psychological distress, potentially greater risk for psychosis. We've identified 30 patients between September last year and April this year. One of those has already gone on to develop psychosis. And we're now applying a precision psychiatry approach and intervention and looking at the feasibility of this. So we're taking people who we've identified, we are contacting first their clinician and then the patient, we're asking them to take part in this project, we're randomly allocating them after baseline to receive either a psychoeducation and treatment choices intervention or waitlist control. We are following them up at 3 months, and then after 3 months everybody gets the intervention. We've had great patient public involvement input all the way throughout, so they've been involved in developing training fields that help demonstrate good practice in how we talk about this risk for greater psychological distress, because we can't be sure that these people will develop psychosis, it's just a greater risk. And we've also had great patient public involvement in co-producing the resources. So there's a very comprehensive treatment choices booklet, which includes lots and lots of information about self-management, as well as interventions that are evidence-based that might be helpful. We've also co-produced regional booklets in each area of Sussex, which indicate where you can actually access those treatments, both locally, nationally, online, for each area in Sussex, and again with lots of patient public involvement input. And what we're now doing is we're in that next stage of recontacting individuals, we're interested in how many service users and clinicians are identified. We're going to do another round of identification later in the year. How many actually consent to and accept the resources, how many meet at-risk mental state criteria based on standard assessments. We also know what people think about this. Do they like it? Do they think this is valuable? Should we be doing more of this in the future? We've certainly had people, service users, who've said they think it's really important that people aren't missed out and don't fall through gaps between services. We want to see, does it make a difference to the number of interventions that are offered, or the number of self-management or other approaches that service users take up, and is there any impact on health and health economic outcomes? We've learned that the risk calculator is not as accurate yet as the King's one, and we're working to increase that accuracy over time with Acrivia. We know that this might be because we had only 10% of patients with a structured diagnosis. So again, we're working and having conversations about increasing this. We've learned that natural language algorithms take a long time to develop and to get accurate, but we now have a number of algorithms, we now have a number of constructs that are available for lots of future research as well. We've co-produced treatment choices and information packs that are available for use for people with at-risk mental states. And what we're aiming to do now, as I say, is try and understand what clinicians and service users think about it, whether it leads to more offers and uptake, and whether there are short-term impacts on mental health. And I wanted to lastly thank the Applied Research Collaboration who funded this project and made this all possible, and it's going to be interesting to see what we learn with the next steps. So that's the end of that presentation. I could take one quick question and then we're hoping for time for discussion at the end if anyone had a question they wanted to ask.